Yes. So
Yeah.
we can start? Okay.
Yes.
Let me
We can.
introduce you, sir. Good morning,
Okay.
all senior colleagues and colleagues. My name is Dr. Lamba Bintu from Dalhatu Arif Specialist Hospital, Lafia. I welcome you all to this fortnight academic session. We apologize for the hitches we had last weekend. We're going to be having a presentation on the first part of OCT interpretation in glaucoma by Dr. Sadiq Abdullahi, who is a mentor and a teacher to many of us here, a glaucoma specialist from National Eye Center, Kaduna. Welcome you, sir.
Thank you very much, Dr. Bintu.
Yes, sir.
I also want to apologize for what happened last week. Is due to some technical issues that we couldn't resolve on time. But anyway, God's time is always the best. So today I'm going to talk about OCT interpretations in glaucoma, which I know many of you are used to. I think most centers have OCT now, or if you don't have OCT, you have access to it. So by way of introduction, glaucoma is an optic neuropathy that is characterized by progressive loss of retinal ganglion cells and their axons. And the diagnosis of glaucoma is based on detection of abnormalities in optic nerve head or retinal fiber layer, both structurally and functionally. Now, in glaucoma, damage occurs structurally before functionally, and there difficulty is one of those methods. Now, but for the purpose of glaucoma evaluation, in the OCT, we're interested in three areas. One, peripapillary retinal fiber layers, the optic nerve head, and the ganglion cell complex. Most of the OCT machine, the Cyrus OCT, the Trison, the Optic, the Spectralis, all of them, they give information about these features. Now, and this is one example. This is what I'm talking about. We talk about the optic nerve head, the retinal peripapillary retinal fiber layer, and then the macular ganglion cell complex. Now, why OCT is important? Because it helps us to diagnose preperimetric glaucoma, and this is type of glaucoma in which patient has high pressure, but visual field is normal, and there is usually associated retinal fiber layer depict or some early signs of glaucomatous optic neuropathy. So OCT is key in the diagnosis of preperimetric glaucoma, and of course also in early glaucoma, and also most importantly is in assessment of glaucoma progression. So therefore, OCT is not one-off investigation. It is investigation that should be performed serially in order to detect if there is any progression structurally before it becomes functional. But then the retinal fiber layer analysis in most OCT machines is presented in this format. It presents information about retinal fiber layer thickness map, retinal fiber layer deviation map, TSNIF graph, global mean of retinal fiber layer thickness. Then they give quadratic measurement and 12 clock hours measurement. I will show that. Now, this is what I'm talking about. Almost all OCT machines, spectral domains OCT machine, they give these informations. This is the retinal fiber layer map. This is the deviation map, and this is the TN, and this is the this is the TSIF. I don't know. This is anyway. So this is what I'm talking about. It compares the retinal fiber layer between the two eyes across the different quadrants of the optic nerve head. And then this is the quadratic distribution. It gives you the average retinal fiber layer thickness in the superior, inferior, nasal, and temporal quadrants. And then this is the quadratic distributions. And then this will give you now the mean of the retinal fiber layer of the patient. So this 1, 2, 3, 4. 5, the thickness map, and then the deviation map, and then it gives you the graph here, and then also it gives the quadratic distribution and then the clock out distribution. I'll come and talk about them later. Okay, now how do you interpret OCT? The sequence, you start with signal strength. Signal strength is very important because you want every machine, the manufacturers have recommended signal strength below which the scan is termed as having a low signal strength. And when the signal strength is low, it introduces some artifact in the interpretations of the visual field. I will show the values for the different machines later. Now, this is the second part. So when you look at, and then one important thing that you need to look at in this OCT is that you see this OD, it shows some green cycles here. Now, this means the signal strength is good. If it's not good, this place will be in red. This will be in red, not in green, and it's shown here. So after you are satisfied with the signal strength, the next area you need to look at is the retinal fiber layer thickness map. In a normal individual, this is the graphic presentation of the retinal fiber layer. Now, in a normal individual, it has a butterfly pattern. So it has a butterfly pattern. And now if you look at this one, now the next one is a deviation map. What this one does is that it gives you the difference between what the patient has and what he should have, the age match control. And now the difference, now if the patient's result is within the normal range, like this one, there's no defect here, so you won't see anything here. But if you look at here, there is some red dot here. So now this area now is the area of thinning. So in other words, the deviation map, it will show you area of retinal fiber layer loss. Now it's coded whether it is yellow, which is borderline, or it is red, which is outside the borderline or outside normal. Now the next is this one. Now this one, it shows we were all aware of the isn't rule. So now, but this one it is telling you the retinal fiber layer in the inferior, in the temporal, superior, inferior, nasal, and superior quadrant. So now, but what if you look at this, it has a pattern. It has a straight line and there's a dotted line, and the straight line is the right eye, while the dotted line is the left eye. Now you compare how the two eyes, as they are moving across the graph, you compare the similarity between the two graphs. Now in the eye that has more loss, you will see that it will be more down on the graph. Now, and as you can see, this is a normal scan. Everything is within the green zone, and we know that the green zone is the normal zone. Now the yellow is the borderline where the red is outside the normal. So the next area to look in the OCT, after you look at these three areas, now the next is now the next is to look at this. This is the neuroretinal rim between the two eyes. You can see like the retinal fiber, this one is thickness of neuroretinal rim. I would also know that from the isn't rule, you should expect to have some double home. This is inferior, this is superior. And also compare the two between the right eye and the left eye. As if you can see in this one, the left eye is a little bit lower here, but superiorly, they are almost the same. And inferiorly here, they are also, inferiorly and superiorly here, they are also the same. And this is the part of the graph that follows the isn't rule, because the information is about neuroretinal rim. Now the next area to look at is the B scan of the optic nerve head. Now, what is the essence of this? The essence of this is to know that the OCT software has accurately mapped out the limit of the optic nerve head from which all other measurements are taken. Now, if you look at it here now, there are two colors. I don't know whether you can see there's a black color here, and now there is area here. This is the interlimited membrane, and this is the Bruch membrane. And then one thing I want you people to understand is that the Kopdix ratio in OCT is not the same as the Kopdix ratio we see with our optic nerve with direct ophthalmoscope or in the or using indirect ophthalmoscope. Using indirect ophthalmoscopes, we look at the margin of the disc vis-a-vis the curve. Now talk about CDR. But in OCT, it used the Bruch membrane. So everything, so the OCT, the software has to clearly outline the Bruch membrane. And then in this one, you want to check the good segmentations, because if you what the OCT does is that it isolates the retinal fiber layer and measure it. So you have to be sure that yes, it has accurately isolate the retinal fiber layer, and the information you are getting is the correct one. So now in this quadrantic distribution is telling you the retinal fiber layer in the superior, inferior, nasal, and temporal quadrants. And now sometimes it's very good to compare the numbers between, okay, for example, you can compare inferior and inferior in the right eye and inferior in the left eye. You can compare superior in the right eye and superior in the left eye to look at asymmetry. So one thing about OCT interpretation is that you should be looking at these parameters and comparing them from right to the left eye. Now this is one example of Cyrus OCT that show the colors. Now, if you look at this color toward the zero, you can see how the color looks something like blue, but up there is green. So what it means is that these are thicker areas. Where you see the blue and the yellow are the thicker areas, but you can see a streak of, you can see a streak of a thin area here. And then again, you also look at butterfly pattern in the two eyes. Is there a loss of the butterfly pattern? And then from there, you now look at the next is the deviation map. So you can see from the deviation map, you can see some areas of thinning. And one of the advantages of the deviation map is that it gives you information beyond the 3.0 millimeter cycle that the normal measurement of OCT are taken. So you can see if there is any defect here, it will show. I have other graph to show. So now you can now see here again what I'm talking about. As you can, so after the thickness map, the deviation map, and the next you go to the TSNIF TNSIF graph. As you can see here, as you can see here, you know, this is superior. It's supposed to be this is supposed to be from inferior superior. If you remember the Ising rule, although this is retinal fiber layer, it does not completely follow the Ising rule, but usually the inferior and the superior tend to be higher. But as you can see here, there are some loss here. And now if you look at this one also, you can see this value is about 90 millimeter and 90 micrometer, and look at this, you can see it's about 97. So you can see from here, starting from here, you can see a defect here, which is reflected here, and you can also see some localized defect here, and then you are seeing it here being demonstrated. And then of course, you shouldn't forget to look at the mean, the absolute, the mean of the retinal fiber layer in the left versus the right eye, and you look at the measurements. And then the same thing here also, you can see some area of defect. Now, this is a patient who, this is a patient with advanced disease. So you can see the right and the left eye. Already there is a loss of the butterfly pattern. And then if you look at going by this color coding, you will see that all the areas surrounding the optic nerve head are within this lower limit. And also in this eye, you don't see the red and the blue around this area. You only see the blue down. So which means there's already diffuse loss of neuroretinal rim in both the right and the left eye. Sorry, the diffuse loss of the retinal fiber layer. Now, in the deviation map, the deviation map will outline those. It will show the areas where the defect occurs. As you can see here, there are superior and inferior defect. You can see all these red areas. You can see all those red areas. They are areas of loss or areas of thinning of the neuroretinal rim, because the difference between the red here is different from the red here. The red here, it means thick area, but this is a difference between what the patient has and then what the patient should have. And now, if everything is normal, you won't see any color. But if the difference is large, it will be coded as either yellow, which is borderline, or it's red, which is outside the normal limit. And again, also if you look at the graph here, you will see that everything is down in both the right and the left side are down. So there's lots of the double hump. Everything is down here within the red zone. And then of course here also, if you look at the quadratic distribution, all the measurements are low. This is for the 3, this is for 3 also, and also in the clock hour distribution. So basically it shows you that there's diffuse loss in this scan. Now this is you will see this is the optic nerve head, and this is the butterfly pattern, and then this is the deviation map. So in this one, everything looks normal. There is no any red or yellow area here. So this looks normal. And then if you come down here, you can now look at the then you can now look at this graph also, and then move here. You can see that you can see the quadratic distribution of the retinal fiber layer thickness, the superior, the inferior, everything is appearing in green here. But then if you look at this one here, you can see there's some areas of loss in the spatiotemporal sites. And of course, when you see this in the spatiotemporal site, when you come here, you also look at the graph. You compare the two between the left and the right eye as it goes up and down along the graph. And then also you look at here, you see these are areas of loss. So in this case, you need to quickly see the CBF. Now, if the CBF is normal and the patient has high pressure, this is an example of preperimetric glaucoma. So what about the optic nerve head? What I have mentioned earlier are all about the retinal fiber layer. And then what about the optic nerve head? Now, the parameters of the optic nerve head depends on the machines you are dealing with. Now, these are the different type of OCT machine: spectralis, Cyrus OCT, Optizoom, Popcorn, Nidec. Now, if you are using Cyrus, which most people have, it's the optic nerve parameters. It gives information about the optics area, the cuff volume, the CDR, the vertical CDR, and then the rim area. But if you're using Topcon give information about the disc area, the cup area, the cuff volume, the vertical cup disc ratio, the horizontal cup disc ratio, and the rim area. But one thing you see consistent about all of them is they give information about the rim area because of its importance in diagnosis and assessment of progression in patients with glaucoma. And all of them also give information about CDR. And then all of them also give information about disc area. So these are very important parameters in assessment of glaucoma and its progression. Now this is Cyrus OCT. As you can see, these are the parameters. These are the rim area in the right and the left eye, and then the disc area, then the abreast CDR, and then the vertical CDR and the cup disc ratio. And it also gives information about the neuroretinal rim. So neuroretinal rims are actually parts of the ONH parameters when it comes to interpretation of OCT. And this is the Triton OCT, which is popcorn. And you can also see it give the rim area, the disc area, and also the vertical cubic ratio and the curve volume. Now, of all these parameters, areas of neuroretinal rim and vertical CDR are the most sensitive parameters for glaucoma detection and progression analysis. And now another important area that you need to look at when you're assessing this, especially in a patient with glaucoma suspect, is the disc area, whether the disc is small, less than 2, or it is large, greater than 2.5. And it affects the other parameters. So the third thing we look at in glaucoma, remember I said we look at retinal fiber layer, we look at optic nerve, then the last one we look in OCT with regards to glaucoma is macular ganglion cell complex analysis. Now we know that the main pathology in glaucoma is the degeneration of retinal ganglion cells. And we are all aware that the highest concentration of retinal ganglion cells are found in the fovea. And therefore, it makes sense if we can have a means of assessing the retinal ganglion cells as indicator of severity of glaucoma or as indicators of the presence of glaucoma. Unfortunately, we cannot assess ganglion cells directly, but they have come up with this ganglion cell complex, which actually includes the innermost layers of the retina, which are the retinal fiber layer, the ganglion cell layer, and the inner plexiform layer. So these are taken as surrogates of the ganglion cells. And one of the advantage of this thing is that it is one of the advantage of this ganglion cell complex analysis is that it is devoid of confounding effect of optic disc variability. It doesn't matter whether the size of whether the disc is small or the disc is large. And also another important of ganglion cells complex is that in early detections of glaucoma, ganglion cells are the one that are affected early before you see it in the retinal fiber layer and the CDR. And also in patients with advanced glaucoma, that is what we call flow effects. And in those, because as the glaucoma damage progresses and the retinal fiber layer reach a certain critical level, any further progressions cannot be detected by the machine. But ganglion cell complex can be detected as the disease progresses. And then also in patients with myopia, in patients with peripapillary atrophy, you can resort to the ganglion cell complex for the diagnosis and progression of glaucoma in this category of patients. And now this is what I'm talking about. They look at the innermost layer of the retinal fiber layer, ganglion cell layer, inner plexiform layer. Now, it depends. Some machines have different combination. Now, if you're using Cyrus OCT, which is the Zeiss, they use ganglion cell plus inner plexiform layer alone. But if you're using TopCon, they give two variables. One, GSL plus plus. GCL plus plus connotes retinal fiber layer, ganglion cell layer, and inner plexiform layer. Well, GCL plus, it detects ganglion cell layer plus inner plexiform layer. Where other OCT machines like Spectralis, Heidelberg Engineering, they measure the individual layer. Now, this is one example of the macular OCT from Cyrus OCT. Now, another thing, this one also, it gives the math of the thickness of the ganglion cell layer, ganglion cell complex. Now, the normal they should have a donut shape, And also remember, this has color coding. You can see this is, as it's moving toward this blue, it means loss. It's going higher toward the red side, it means they are more healthier. Now, if you look at this one, you will see that around this area, there is loss of the thickness. There is loss of the ganglion cell complex around this area, and this area tend to be healthier. And now this one is the deviation map. So it tells you the defect, area of the defect in the, so this is like the deviation map in ganglion cell complex, and these are the areas of defect in this one. Now, if you can see this one, This seems to be a little bit healthier. You can see more areas of yellow mixed with some area of red. And therefore, you can see the defect here is not as extensive as here. So the defect is not as extensive as here. And it also gives a quadratic distribution of the defect, as you can see here. Also give you the average of the ganglion cell complex in the right and the left eye. And also it's very important also the centration. Talk about that later. Now, if you are using Triton OCT, like I said, it gives three. So in Triton OCT, this is retinal fiber layer. This is GLC plus. This is retinal fiber layer thickness alone. This is retinal fiber. This is ganglion cells plus inner plexiform layer. That's GLC plus. And now this is GLC plus plus. Ganglion cell, retinal ganglion cell layer, inner plexiform layer plus retinal fiber layer. And like in the previous graph, it also followed the donut shape. And it also followed this color coding. As you can see, toward this side, it's an area of loss. And as you see, go to the yellow and the green, it means they are normal area. So you can see in this one, that's completely everything is lost here. So you can see diffuse loss of the retinal fiber layer thickness in the macular area. And then in this one, you can also see the defect outline and also defect outline, and you can see it gives you the superior and the inferior value, and then it gives you the total. So this is very important in early and in advanced disease. OCT is like any other imaging. It can be affected by artifacts that can compromise the readings. Now, the common one is the signal strength. Every machine, like I said earlier, it has a value. Now look at this. This is the cutoff value. Now, if you're using Cyrus OCT, the signal strength has to be more than 60. If you're using Triton, more than 35. If you're using Spectralis, more than 30. If you're using X Avantis, more than 50. Like I said, the good thing is that the machine will tell you by itself that there is low signal strength. And the commonest cause of poor signal strength is media opacity, cataract, and then other form of opacity like vitreous opacity, and even corneal edema. Now, this is important. This is a very significant error because it gives false thin measurement of the retinal fiber layer, ganglion cell inner plexiform layer, and ganglion cell. Now, this is OCT of the same patient taken on the same day. Now you can see the first scan shows poor signal strength. And you can see all the loss, all these red areas that show area of loss. But now I ask them to dilate the patient a little bit and repeat the scan. And now this is what I'm getting. So you can see this is with low signal strength of 32. I remember I told you now, you can see this is green, green. This is red, red. So the machine itself will tell, once you see red, it's like alarming you. This is poor signal strength. So everything becomes thin here. But the same patient, now everything become green. So erroneously, if you look at this one without looking at those parameters, you can quickly go ahead and say the patient has advanced glaucoma or the patient has pre-perimetric glaucoma and start the patient on medications. Meanwhile, it's on artifact. Now, another thing is, you see, look at this. Look at this one. You see, this one is perfectly centered. And look, this one is decentered. So this is what we call decentration error. This should be centered. It should be centered. So when you look at, although the patient has good signal strength, but this one is compromised by the decentration. So the result of this right eye cannot be reliable. But you can see this one. And even this one, you can see on artifact here, this is called blinking artifact. When the patient is blinked, and that was when the something was taken. And that's what's showing here. Now, if you look at this one carefully also, you will see that if you look at this Kundal photo, you will see that it's not there's no complete cycle here. The optic nerve area is not completely outlined. And this is what this is reflected here. And if you look at the butterfly pattern here and compare with this one, you can this is like hub pattern, and you can see this dark band here also. So this one is also as a result of motion artifact and blinking artifact. But you can see this one is also another form of decentration, and therefore look at these results and look at other everything looks normal. So but this one now cannot be. So we repeated this result, and this is how it comes out. Now this is the same patient now when we repeat it, and this is how it becomes. So everything now become normal. So this is what I have for you. OCT is an integral component of glaucoma progressions. Like I said, it's just one part of the presentation. We can also use OCT to assess for glaucoma progressions. There's also place of OCT on geography in glaucoma, and then anterior segment OCT in glaucoma diagnosis. So these are other further topics that need to be discussed. Thank you very much.
Thank you very much, sir, for this very elaborate and rich presentation.
Yeah.
We really appreciate. We entertain questions and comments. Please, you can indicate by raising up your hand, or you can type in the chat box. Thank you.
So there's no question.
YouTube. Okay. Question. Dr. Bint.
I've been muted. Dr. Kwanaki, please, you can ask your question. Hello, Dr. Ibrahim.
So I think we can start taking.
I can't see the questions.
Did anybody type? I think somebody raised up his hand, so I'm trying to make him.
Okay, somebody type, how can the B scan in OCT help in diagnosis of glaucoma? So what I'm saying is that the B scan, it will help you to know whether the OCT software has clearly delineate the margin of the optic nerve head for assessment. Because what the machine does is that it first of all isolates and demarcates the whole of the optic nerve head and the internal limiting membrane. I mean, that means it has from the beginning, the outside to the innermost parts of the optic nerve head. And then from there, it now calculates the curve disc ratio, it now calculate the retinal fiber layer thickness and other things. So if the first outline is not properly done, then certainly,
You need to
then
bathroom.
now if the first outline is not perfectly done, then all other measurement taken will be wrong. It should not be correct. And that is why step-by-step assessment or step-by-step assessment of the optic nerve of the um, OCT scan is important.
Even the one. Okay. Okay.
Yeah. How reliable is vertical computation in OCT? Since it is how reliable is vertical curve disc ratio in OCT, since it is a more objective measurement when compared to our own observation by CDR? Of course, one of the advantage of those measurements in OCT is that they are objective, they are reproducible, unlike the one we take using during clinical evaluations that is really subjective and has a high inter-observer variability. So it is more reliable and it's actually more correct because it measures, it doesn't include the discs in the assessment of the cup disc ratio. It starts from where the nerve enter into at the Bruch membrane. So that's it. And then you see one thing about all of these parameters, when you come to glaucoma progression, that is what the machine used to assess for progression. So these three areas that I mentioned, the retinal peripapillary, the optic nerve head, and the ganglion cell complex, all the parameters in this one, the machine will take them over time. If the patient has 3 or more readings, it will automatically generate progressions using one of them, each one of them. But before you do that, you must ensure a good quality scan, the one that has good signal strength, no decentration error, no any of artifacts, and is well demarcated. How does peripapillary retinal fiber layer traction affect? Of course, it affects it because it will not the machine cannot accurately
I think we lost him.
He's trying to join us again. I just chatted with him.